Dr. Paul Farmer is a physician who has dedicated his career to improving healthcare for the world's poorest people, and has written extensively on the role of social inequalities in infectious diseases and global health. Dr. Farmer is the co-founder of Partners in Health, an international nonprofit organization dedicated to bringing medical facilities to impoverished people. Dr. Farmer currently serves as the chair of the Department of Global Health and Social Medicine at Harvard Medical School, and as a professor of medicine and chief of the Division of Global Health Equity at Brigham and Women's Hospital. Paul Farmer has published numerous books, including To Repair the World, as well as Pathologies of Power, Health, Human Rights, and the New War on the Poor. We are honored to have Dr. Farmer with us today to talk about the pandemic from a social equity standpoint. Interviewing Dr. Farmer is first-class Mason Wells, an aerospace engineering major, who is the co-director of academic content for the Naval Academy Foreign Affairs Conference.
Dr. Paul Farmer, on behalf of the Naval Academy and the Foreign Affairs Conference, I'd like to thank you for your participation in this keynote address. You have a very diverse background. You have a history in specializing in anthropology and medicine, and you're well qualified to speak on the medical disparity that exists between more developed countries and less developed countries. And so thank you very much for being here.
A pleasure. Thank you.
So I want to get straight into the heart of the issue, the unequal distribution of the COVID-19 vaccine.
Yep.
As it stands right now, the US has distributed 130 million vaccines, China 82 million, the UK stands at 28 million delivered. Yet the world's leading COVID-19 humanitarian effort, COVAX, has only shipped 32 million doses.
Yeah.
What's going on? Why is that?
Well, I think one of the major pathologies there, Mason, is that when these were put on the market, that the countries with the most power bought up the existing supply even before it existed. So, and we kind of knew that was going to happen. It would be typical of previous, there hasn't been anything like this in my lifetime, but typical of other smaller crises that required something like a vaccine or a medicine or a diagnostic. I'm familiar with that, and I'm sure you are too, the history of that. But then after COVAX was established, and I'm proud that the United States made a $4 billion commitment. When COVAX was established, things were lined up to look a lot like they are now. And that's why last fall, a number of countries in Africa, particularly about maybe all of them in the African Union, pushed for a waiver of the trade-related intellectual property agreements. I don't know a lot about that, Mason, but I know enough to know that they're probably right. So now we're in a situation where even though we're going to have excess in some countries, we're going to have very little in others. And that's one of the reasons my colleagues in Rwanda are thinking very seriously about boosting local vaccine production. There are other reasons too, but that's one of them.
So you mentioned that the US contributed $4 billion. There's other countries, many countries that have donated significant amounts to make that all happen. What do you say to countries like Russia and China that, to my knowledge, currently have not donated any money whatsoever to COVAX?
Well, I first of all, you got me there because I didn't even know which countries had donated to COVAX. They also have very brisk, some people are calling it vaccine diplomacy. They have very brisk vaccine diplomacy efforts. And they tend to happen in either their spheres of influence or the spheres they'd like to influence.
Of course.
And, I don't think that's that different from what goes on in Europe or North America either. So Russia has developed a vaccine that's not unlike the Ebola vaccine that really helped cut short a couple of epidemics. That is, it's not a messenger RNA vaccine. It's a vaccine that uses a live and harmless virus to deliver the antigen that would trigger the production of an immune response. And there's been quite a bit of that vaccine, the Russian vaccine, reaching Latin America. And that's what I've heard. Also the Chinese vaccine. And as you know, there's a lot of debate about one of the other vaccines, the AstraZeneca vaccine, which seemed to be less effective against some of the variants emerging in South Africa, in Britain, and in Brazil. So I think there's going to be a lot of mess like that in the coming months. We're going to be scrambling for a number of different kinds of vaccines. We'll be pushing for vaccine production on the continent of Africa, as we also, try to see which vaccines work as well as the others. And that's going to happen in real world studies that are ongoing now.
Mm-hmm. So for countries like, say, Nigeria or Uganda that aren't in the middle of this vaccine development, this distribution, is COVID-19 really more of a problem than, say, malaria or HIV?
Well, it's not a bigger problem than malaria, and maybe a bigger problem than HIV. So it's not a bigger problem for Nigerian children, probably, and Ugandan children. Their malaria is the ranking threat to health and life. But HIV, and this is something that should inspire a little bit of confidence. HIV has been reduced substantially on that continent, and I understand that Dr. Fauci is going to be speaking to this conference as well. He was one of the architects of that program, which was launched under President George Bush, called PEPFAR, President's Emergency Plan for AIDS Relief. And when the math is done on that effort will have saved. It's still saving right now over 20 million lives of people who need the medications, but think how many new infections were prevented with these medications too. So when you look at examples like that, you can see why HIV may be a less ranking problem than COVID. And in other places, it'll be a greater, in other communities too, it'll be a greater problem. HIV will be. And then there are some parts of Africa, as you know, you mentioned 2 malaria endemic regions or countries, Nigeria and Uganda. And there are other parts of Africa where that's not a big, malaria is not the ranking killer of children. So each part of that continent, like each part of the United States, has a different set of challenges right now to roll out the vaccine. But all of them, I think all of the actors, as they say in foreign affairs, are really keen to do it. So we really have to focus on distribution, as you said, through COVAX and other mechanisms, no doubt, but also thinking hard about local production and local capacity building, which we should always be thinking about in this kind of work.
So you say that, we do need to focus on the distribution. And can more developed countries make a lasting impact if the aided country in question has an unstable or even a partially corrupt government? I mean, what lasting change can occur when these more developed countries are worried about bureaucrats taking 50% of the donations off the top?
Well, corruption occurs in many forms and in many places. There's been industrial strength corruption in the United States too, as you know. But I feel pretty confident saying, after 30 plus years working on these projects, that there's always a way if there's the will. In other words, there's a way to avoid corruption if there's the will on the part of those who call themselves the donor class or a donor nation, right? Let me just give an example. If you thought there was corruption at the central level, meaning in a capital city, in the executive branch, which would include their health appointees, then what's stopping you from working with a district health officer or in a district? So we don't always have to cover everything and do everything. In our work with Partners in Health, we've gone through so many coups and governments in Haiti, and not just Haiti. There's been tumult even in Peru, in Liberia and Sierra Leone. In fact, one of the places where there's been the least kind of disruption like that has been Rwanda. And not surprisingly, work in health and health equity moves forward much more quickly there than it does in other places. But that's not to say that a lot of progress has not been made in Haiti, which has endured that kind of instability. So I'm a real believer that we can always find a way to shore up public health, meaning through the public sector, if we stick with it long enough and don't just try to go it on our own. So
in your opinion, where it stands now, is a large-scale world response kind of the answer, or are NGOs, as they've been many times in the past, kind of the primary vector we should look at when it comes to this?
Speaking as someone who is a volunteer for an NGO, I'm going to say I think it is a global world response where the governments and the international governance institutions need to come together and be part of this. NGOs, community groups, women's groups, all kinds of groups, and endless institutions and organizations can be part of this. But this is so big that it requires really concerted global effort. And that's not going to happen if we don't get the governments on board too.
Well, that's an interesting thought. There are many that have noted in the past that the World Health Organization has possibly cherry-picked analytical tools to treat wealthier countries first. And do you think that still occurs? And is there a way to fix that within the international system?
I think with the current World Health Organization leadership, the Director General is from Ethiopia himself, and he's a malaria researcher by training and has been involved in this work in the hard way that a malaria researcher in Ethiopia might be, in addition to all the other things he's done since then. I think he's really very strongly focused on the continent of his birth and on poorer countries, right? And that, I wouldn't say that's new, but it's newly underlined by this current administration. What they lack is the same thing that Partners in Health lacks, which is resources. A lot of people hear of World Health Organization, they assume that it's a well-heeled outfit. It's chronically underfunded, like a lot of public health endeavors in the United States too. So we would like to not only be supportive of the World Health Organization, but try and get their support too on regulatory issues, on the symbolic value and the real value of pushing forward local capacity building in Africa, including vaccine manufacturing. So we intend to do that. And we're pretty confident that, you know, it is an inherently political animal, right? And it is run by the ministers of health from all the member states. So it's really hard, just like the UN or some other, it is a UN, part of the UN, but this is always hard because it requires a consensus that is often difficult to get. But on COVID, we can get that consensus, right?
Yeah. So digging in a little deeper there, Partners in Health, what are you doing to increase buy-in during this time? A lot of these donor class individuals, they're worried about their loved ones, those closest to them, not necessarily people on the other side of the globe. So how do you create that sort of buy-in for people overseas per se?
Well, you know, I will say that last year at the beginning of this, or last year at Partners in Health, there was a lot of concern raised by our colleagues, members of the board, people working in Haiti, Rwanda, et cetera. Are you guys going to lose interest in this work because now you're at the epicenter of a pandemic? And of course we said, no, that's not the way it's going to work at all. That's why we built Partners in Health to be run by local people serving their own communities. We're going to be with you no matter what. Even if we can't be there physically, we'll be there with you. Now, that was something that I'm proud we said 13 months ago. Yeah. But it also came to pass. First of all, we haven't seen a sharp reduction or any reduction at all in donations to Partners in Health. And most of our donations come from Americans. And that's a good thing because as a country, we were doing uniquely poorly in responding to COVID with all the numbers you guys have to see every day and the horrific death toll. And still, we did not see people turning away from this kind of pragmatic solidarity that we're preaching, saying we all have to chip in. This is a global pandemic. You know, even going back to the World Health Organization, is it a good idea to resign from the World Health Organization during a global pandemic, the likes of which haven't been seen in a century? No, it's not a good idea. You know, that's like burning bridges with your allies, you know, in a military campaign.
So that kind of leads me to another question about the damage that's been inflicted by COVID-19, because normally we would expect the worst damage on poorer places.
Yeah.
But death rates as well as case rates are much lower in Africa and Asia, COVID-19. I'll throw out a few case numbers if you'll entertain me. Africa, 3 million confirmed cases. The Eastern Mediterranean, 7 million confirmed cases. Go over to Europe now, we're at 43 million cases. The Americas, 54 million cases. Are these case numbers accurate? Is this data accurate? And what story does it tell about COVID-19?
I think it tells two stories. One is the story that will be underlined a lot. And I'll go to a third story that I don't think it tells. The one that is underlined a lot is the question of poor surveillance, poor reporting, and limited testing. Those are real things, right? If you're in a clinical desert where there's no labs and nobody's doing testing, you won't find any cases. You can guess if they're short of breath and febrile, but it could be TB, it could be pneumonia, bacterial pneumonia. So that's one case that I'm saying I don't believe that we can account for the lower caseload in Africa based on poor reporting and poor surveillance. Then there are a second group of matters which are probably very significant. The age structure of the population, the rates of comorbid disease, obesity, diabetes, heart disease, and of course, as I said, age, by talking about age structure. Those a priori make for very different epidemics, right? Because it's a different population. But don't forget that some of these places may be doing a good job. Like the only place that I've spent time during COVID has been in Rwanda. And I spent a month there in about, I think, month of August. And, really, I enjoyed myself, but I don't think I contributed much because they were doing a great job. They were practicing social distancing, wearing masks, even in rural areas, in these little tiny villages, where they're sitting outside on a chair in front of their tiny house with their masks on. And I'm from Florida, and I can tell you that's not what it was like here. And so let's not underestimate the ability of some places, and Rwanda is a standout, to do a very good job on a public health effort that relies on containment. So that gets us back to the United States. As you will recall, there was a lot of skepticism about containment efforts, especially at the highest levels of government. Of course, that becomes a self-fulfilling prophecy, right? You say we can't do the containment, we can't do contact tracing, we have to wait for the vaccine. Well, that's going to be a self-fulfilling prophecy. Right? And then there's a third level so the first one is don't blame it all on poor surveillance. The second is some of these places have done a good job, right? I mean, if you look at Asia, look at Singapore, China, Taiwan, some of the countries there have done a very good job at controlling even before the vaccine was available.
It was already a cultural thing.
It was already a cultural thing. It was already a structural thing as well, with the ability to enforce regulations that we probably don't even have here. And I kind of like living here. I like living in the United States, but it's a setup for a poor quality public health response in the absence of vaccines. And that's what happened. And the third set of issues that I think we have to be very skeptical about when we're thinking about disparities of risk and disparities of outcome is to assume that everything is related to some genetic factor. Black people have less risk. That's why Africa is spared. These are very common 19th century and early 20th century explanations, right? That focus on some genetic, it used to be called hereditary difference in risk. I don't think we're going to find a lot of, I don't think we're going to find that accounts for much of anything, frankly. More likely than mutations in the human, it's mutations in the pathogen, which may indeed alter the rates of infectiousness or virulence. And I know those are terms that I would not have used just a couple of years ago at a talk to midshipmen. But people now recognize what virulence means. Is the virus more deadly? Or what increased infectivity means? Is it more readily transmitted? And I think those are more likely to account for some of these differences than hereditary or alleged essential or basic or hereditary differences. So this is what happens in the middle of a scary pandemic or epidemic, is there's a profusion of explanations to account for these differences. But a lot of them are goofy. A lot of them are not serious hypotheses, right? And many of them are also they're treading along very well-worn paths that have us, instead of looking at the social conditions of people, has them looking at an individual. And that's not the way to understand this pandemic. It's spread from person to person. Viruses can't even really survive outside of humans. So it's all about the social context, the nature of transmission, and how it's slowed. Now, I'm embarrassed, Mason, because I gave a little lecture there and I didn't mean to, but I know
this is all terrific stuff. And what it does is it kind of frames the public response for me a little bit, hearing all this, because there's a term that's being thrown around quite a bit, vaccine nationalism.
Yeah.
And vaccine nationalism is a term that's being used to describe the tendency of countries to vaccinate their own citizens first before worrying about other countries. And Do you find that strategy ethical per se?
Well, I mean, it's not the strategy that I am hoping for,
Hmm.
but I'm not the president of a country or the health commissioner of a district or the secretary of health and human services. And I understand, or the governor of a state. And I understand that leaders in this country are elected to serve the electorate.
Hmm.
So we knew it would happen, right? We knew vaccine nationalism would happen, and we knew we weren't for it, but we understand the pressures on, the elected officials. Like the president of Rwanda, if he wants to develop a local production for the vaccine for the whole continent, he can, I believe, or should.
Hmm.
But of course, he's the president of Rwanda, so he'll have to think about the 12 million Rwandans first. So is it ethical? Well, there is a different ethics that would have us looking only at the global vulnerable, wherever
Hmm.
they may be. A lot of them are in the United States, as we learned to our distress last year. But we need to also understand what they have to do as elected officials. And I would say it's a different kind of ethics rather than it's unethical.
Hmm.
I'm 61 now. I know some of these people. Some of them are my age, right? The people we're talking about, ministers of health, even heads of state. I know some of them, and I know the intense pressure that they feel to respond on behalf of their own people. And I get that. There are all kinds of nationalism, but you can kind of understand a nationalism that has you trying to protect the citizenry. And I'm sympathetic towards it. It's not what we're pushing
Hmm.
for, but I don't have a critique of it.
So, for countries like Australia, the UK, France, Germany, Canada, these countries that have larger amounts of doses, more easy access to the vaccine, do you think that this idea of vaccine nationalism, of getting to their people first, may hurt them down the road?
Well, sure. I mean, also the countries that you just named are also former colonial powers.
Hmm.
Even Australia, New Guineans would say that, and lots of other places.
Of course.
So they have a different set of obligations, right? I
Hmm.
mean, like the United States federal government better be worried about Guam and Puerto Rico, and
Hmm.
so there are other sets of ethics as well at play. Like, what are the historical underpinnings of so much of this disparity? Where did it come from? People in the middle of a vaccine campaign don't have time to think about that. I understand that. But
Hmm.
this is the backdrop for our global inequality today. And so I would say that the British, the Germans, the French have an obligation to think about the other places in the world to which they've been so long connected.
Hmm.
I think we do too. And even if we didn't, and I imagine Dr. Fauci will talk about this too, the way that Dr. Fauci often talks about this is, do we have a moral obligation to help the others who are in greater need? And he'll
Hmm.
just say yes. I'll bet you he says it at this conference, right? And I agree with that. I also will sometimes keep my mouth quiet, a mouth shut on vaccine nationalism, especially if it's a beleaguered head of state, trying to protect a population that's at greater risk than, let's say, people in, I shouldn't say Sweden because they haven't done a great job, but you know what I mean. So there are so many different ethical frameworks at play. But for the midshipmen listening, I would encourage us not to give up on a moral framework that says, uh, feed the hungry, clothe the naked. And
Hmm.
that's what I learned in Sunday school in Catholic Church when I was a kid. I never understood it, right? They called those the corporal works of mercy: visit the prisoners, bury the dead, right? And then you grow up and go into a world like the one I did and still am in, and you say, oh, wow, it is not straightforward to bury the dead. What are we going to, it isn't that straightforward to get clean water to
Hmm.
people. But those are moral obligations that I think everybody who's human should worry about. And that's why I'm here at this conference. I want you guys to all worry about it, and gals.
Well, going back to Partners in Health, your time in Haiti and Peru, over the course of your treatments of all these different individuals, all these people that were coming to you, uh, it was noted in one of your biographies, Mountains Beyond Mountains, that there was a large tie, in your opinion, between the socioeconomic status of the people coming in and your ability to care for them, the ability to have a medical infrastructure. Can the medical gap in impoverished countries be solved without solving the socio-economic gap that exists?
It can. It can indeed. It's not clear that that's how we should proceed, right? It would be great to attack both those problems at the same time. I mean, look at some of the work that the U.S. military, including the Navy, when they steam up, steam up is still a word.
Steam
when
up.
This sounds totally wrong.
We still use steam sometimes.
Well, you probably have nukes that can power things faster. My point is, my experience after the earthquake in Haiti in 2010, which was a very, very difficult time for me, I must say. And, just because of long proximity and losing a lot of friends and coworkers, when a giant kind of, to you, probably kind of ugly retrofitted tanker called the Comfort shows up, you suddenly have 16 operating rooms right off the shore of Port-au-Prince, and so you didn't do anything to alter the conditions, the socioeconomic conditions, but you brought a bunch of ORs online for people who were running out of time due to being trapped under buildings or having crushed limbs, whatever it was. That saved a lot of lives, right? And I think that's a great thing. Now, fortunately, a group like Partners in Health, which is rooted in Haiti and was there for a couple decades before the earthquake and is still there, we could work with the folks on the Comfort more easily because we also had hospitals to which we could transfer patients who had been operated on there and needed somewhere to recover. So I'm just saying it's hard to have kind of an ideological view on this. In the middle of an emergency, you take the good help you can get and understand what are the underpinnings of this emergency. And that's kind of what I feel we do every time we respond to an emergency of some sort, a crisis, is that we really know why we're there, which is to make those long-term investments at building local capacity, building local systems. Like when we went to West Africa in 2014 to fight against Ebola and take care of Ebola patients, we did it knowing we would still be here in 2021, and so we are. But what are we doing there? Building local capacity, building local infrastructure. We're right now building a major women's health center, in a big hospital actually, in the middle of rural Sierra Leone, because that's what we know is going to reduce their risk of another catastrophic series of problems like Ebola, not because they have hospitals, but because they have trained medical personnel and who know how to protect themselves while responding. So again, I feel like I was giving a little bit of a lecture, Mason, but it's not true that we don't need short-term interventions as well. They just have to be good, as I said. They have to be clearly supportive of these long-term needs or contribute to them, and that shouldn't be easy. That shouldn't be difficult to do.
Well, let's dive in a little bit more to these long-term needs. When it comes to crises, when it comes to, for example, a pandemic, when the time to act has come, the time for preparation is past. You're now dealing with this front and center. And so how do we institutionalize good care in some of these countries? We talk about bringing institutions over. How do we make it a permanent part of the system?
Yeah, nice question. We call that inside Partners in Health just making the pivot, right? When you're in the middle of like just as a person, you're a doctor, say, and you're in the middle of a place where there are lots of people crushed by buildings and still alive, you know what to do. But that's not rebuilding the health system. So it was the same with Ebola. But we did it more quickly. We made the pivot, not away from Ebola patients, but towards restoring general services and opening hospitals and clinics that were shuttered, right, because of Ebola. So that pivot requires staff, stuff, space, systems, and a lot of support. But it's not rocket science. It's not like a nuclear powered ship, it's basic, and it requires sustained attention and at least a modicum of resources, but it's not as confusing as people are making out to be. respond to the emergency in front of you, the wounded person, the ill person, and you think, how can we make this less common? And you can't do that without staff, stuff, space, and systems. So what if you're in a place like Liberia, which doesn't have, in that country, when we got there, there are probably fewer than 50 physicians practicing in the whole country. I have 50 physicians. Wow. I have 50 physicians in my office every day at Harvard, right? So I'm exaggerating a little bit, but not much, I'll just to give some color, at the Brigham and Women's Hospital, which is a great hospital that I work at in Boston, we have 11,000 faculty members for one hospital. Sorry, at Harvard Medical School, we have 11,000 faculty members at one medical school. And, 11,000, I mean,
you're not going to see that in less developed countries. Not going to
do that. But what we can do is start, how do we train people? Universities, teaching hospitals. So we have to build those universities and teaching hospitals. And that's why we launched the new university in Rwanda a few years ago, to address the most time-consuming important matter, which is building local capacity. And the way you do it at the Naval Academy is to really openly encourage the midshipmen, the students, to want to become leaders. And of course, that's what we're doing in Rwanda too. And guess what? They do want to become leaders. They do, whether they're training in medicine or nursing or research or management, they would like that. And, I should have understood that in the 80s when I was, in my 20s. But it took me a while to understand that you have to listen more closely to people like in Haiti who were saying, I really want to go to college. And I would say, yeah, but I'm a doctor. I'm here to provide medical care. And they would say, and I did provide medical care and you got better. And they say, that's why I'm back, because I'm better and I want to go to college, or I want to go to high school, or whatever it was. Back then it was high school, right? Now it's graduate school, because we are making progress in Haiti. So I think by way of self-critique, I was a little bit obtuse and not paying enough attention. And eventually we listened enough and started our own university.
So you talk about how some of these responses to fix these issues, they're fairly basic.
Yeah.
Going back to COVID-19, pivoting a little bit, what is the most pragmatic response right now to COVID-19 in impoverished countries? You mentioned countries like Rwanda. They have the infrastructure from previous diseases that they've combated. What's the pragmatic response right now?
Well, I'm all for saying, okay, let's make vaccination rollout the number one priority. But even there, look at the way the vaccine rollout is happening, not good or bad, but right now we're using only risk criteria like elderly people first, essential workers, et cetera. That means that we're not using the vaccine to respond to outbreaks, right? But that's how we helped stop the Ebola epidemic, was to use the new vaccine to respond to outbreaks. And by the way, since I believe Tony Fauci is going to be here, again, that man has done so much for the world and so much for our country, but he helped to launch the Ebola vaccine as well. He's kind of like our Minister of Defense, and I'm the Navy SEAL of global health.
Gotcha. Well,
and so I there's a lot of things I keep learning from him about these high level questions, and I'm focused on some of the implementation and know a lot about that. And I would say the number one priority is still to focus on the vaccine and the mitigation measures, as he calls them. But don't forget, there are going to be outbreaks for years to come, no matter what. There's still going to be outbreaks. So is there a role for vaccination there? It's called reactive vaccination or ring vaccination. I think there is. So there's a lot of things that I could say today, this is the top priority, and it may be different in a month. In fact, it will be different because things are changing so rapidly. And a lot of it has changed toward the better, but in the last few days, we've had very troubling number of new cases in the United States and a large number of deaths. I mean, it averages out to 1,000 a day, which is tragic.
Well, yeah, thank you for putting it in terms that I can understand. And when we're talking about this vaccine rollout, you mentioned targeting specific outbreaks. Something we're not talking about as much is some of the economic impacts from COVID-19, which are tremendous. And Diving a little bit into it, for example, the World Bank is saying that interruptions in the economy related to COVID-19 are going to push an additional 90 million people around the world into extreme poverty. That's kind of a low ball. They estimate another 100 million will be pushed into acute food insecurity. That's really just the tip of the economic iceberg. At what point are we getting to a point where maybe the response is becoming worse in certain areas than the actual disease?
I have no doubt that there are settings in which that's true.
Mm-hmm.
I don't live in one,
Mm-hmm.
but I know for sure there are places like that where the lockdowns are so rigid and fixed that people are suffering more from the trauma of disconnection, losing their jobs, etc. The toll of that is really horrible. I'm not one of those COVID shamers, really.
Mm-hmm.
I understand the suffering. I've lost friends and family, but I've also seen the impact on friends and family and on their livelihoods.
Mm-hmm.
And it's been very extreme in some of the places I work, including the United States. So I really do get that. I think if we could think of these next few months, as the sprint at the end of the marathon, we'll see two different curves. One in which mortality plummets, and the other in which it still declines. But in between those two slopes, there's a lot of loss, and that's just been so painful this past year to see.
Mm-hmm.
I knew it would be bad, but I wasn't sure it would be this bad.
Yeah.
In terms of deaths, and that's very, very painful to see. So we have to be cognizant of the extreme impact that's still not even well understood.
Mm-hmm.
But I would just add one thing. If you look at that figure that you gave about COVID pushing people into extreme poverty, in almost all studies of what moves people from poverty into extreme poverty or destitution, the number one cause has been health crises.
Mm-hmm.
The difference is that those were family health crises, like your mom gets cancer, right? Or your daughter gets cancer, or somebody gets AIDS, or whatever it is, or trauma. But this is affecting everyone, right? This is affecting everyone. So I'm not surprised by the number, and certainly not by the trigger, COVID, but this has been the way of it for a long time. And whenever we don't have social safety nets that include health insurance, we see this again and again, that the number one cause of tipping people into destitution in the world in most studies is major catastrophic illness.
Mm-hmm. So, speaking of those safety nets, there's countries like, for example, Norway or Germany that have bigger social health care systems. They have kind of those safety nets. Am I kind of correct in saying that for many of these impoverished countries, say in Africa, the middle of Africa, or in Southeast Asia, those safety nets don't exist?
Well, they don't exist anywhere near as much as they should.
Mm-hmm.
But for example, Rwanda has a national health insurance program that it launched in 2005, I think. And, again, I'm not proud of this, but I was very skeptical. I was saying, oh, come on. They're going to enroll everybody in a health insurance scheme, a community-based health insurance scheme, but they did. I kept my thoughts to myself and just worked on the project. I worked on, I chipped in too, meaning I did my bit as a physician out in the boonies, right? But I was wrong. They could do that, and they did. So I think if they can do it, it's poorer than Haiti. It won't be for long. The more they invest in healthcare and education and gender equity, the more quickly they seem to leave poverty behind. So it won't be poorer than Haiti for long, but they really do lack staff, space, and systems. So to address those problems, they also developed new training programs. They also built new hospitals. And we were lucky enough to work on 3 of those. So I think there are things going on in Africa. And as you mentioned earlier, they have historically done a pretty good job on vaccination, right? So they have high rates of coverage in most countries. Yeah, there's some problems. They tend to be around conflict zones. But I'm optimistic that if Rwanda can do that, for 90% of the population, if not more, then Uganda can do it, and right through the list. And I think a lot of this, one of the things that I saw when I went to West Africa for the first time, I went from Rwanda, where I was living, and I met with the big shots in the government, and in Sierra Leone and Liberia and Guinea. And to a person, they said, "Hey, we know about Rwanda. We know that Partners Health has worked there. Can you do here what you've done there?"
Mm-hmm.
And so again, even though a lot of people outside of the continent don't know about some of the progressive social changes that have been unrolled, they're there and they're well appreciated, I think, now on the continent. So I'm hoping that Rwanda will continue to be a model for how best to invest public resources in health and education.
Yeah, and Rwanda really has done a terrific job in many aspects.
Yeah.
A lot of their neighbors, they've had some difficulties. And, a lot of these impoverished countries, they kind of become a we take what they give situation. That is to say that they're taking the help they can, but it's really kind of incumbent on the donors to keep that flow coming. I mean, realistically, is there anything that will motivate the world to invest in these countries more heavily?
Well, nothing more motivating than a global pandemic.
Mm-hmm.
I hear people saying this a lot now, we're not safe until we're all safe.
Mm-hmm.
I don't know if that's epidemiologically true, but it is morally true, and it can be epidemiologically true. And, so there's, again, I've seen more articles in the mainstream press these days about vaccine inequalities, vaccine nationalism,
Mm-hmm.
than we've ever seen before. And there's been vaccines for 100 years and change. So we're seeing a new discussion. And here I am back at the Naval Academy having this same discussion with you guys. And I think that's very reassuring to me that there's going to be wider spread appreciation of the need for global and pragmatic solidarity. And by pragmatic
Mm-hmm.
solidarity, I mean, yeah, we stand with them, but how? Well, the United States developed these vaccines, or some of them. That's a great way for us to stand with them,
Mm-hmm. So, kind of wrapping it up, when it comes to coronavirus and these less developed countries, what should we be paying attention to the most?
I would focus on a couple things as for all of you.
Mm-hmm.
I would keep following the vaccine rollout pace as you're doing already. I would ask real hard questions about building local capacity, so that I mean, it's a big world, and having everyone dependent on a handful of countries for vaccines. I mean, we're going to need billions and billions of doses a year. So that's another thing. I'm always looking at case fatality rates.
Mm-hmm.
You brought it up. I didn't bring it up. You brought it up, and I do the same thing. I said, why would 10% of COVID patients die in this city and less than 1% in that city? And then you
Mm-hmm.
say, okay, let's compare by age, and you still see these really striking disparities. So I think those are key issues to think about. And and there are lots of groups, and I'm sure some of them have a presence in or around the academy,
Mm-hmm.
who are, including student groups, who are working on this. I work with a bunch of student groups, including one called PIH Engage, which is really works with Partners in Health.
Mm-hmm.
And I use them to brief me on what's the latest on the vaccines, and I mean, really, pretty much exclusively. I rely when I need an update on what's going on with the vaccine, even in a place where I work, like Rwanda. I still ask them. They're stuck here. They're not going to be moving. They're not going to be headed to Rwanda anytime soon. But there's still a lot that they can keep an eye on. And I think
Mm-hmm.
vaccine manufacturing is up on that list.
Mm-hmm. Well, Dr. Farmer, parting shots, is there anything else that we should be more conscientious of when it comes to the medical systems in these countries that face the disparity that, like we've talked about?
First of all, I don't have any critique of the attention you've given already.
Mm-hmm.
But one thing I often share with medical students or residents, young doctors that were involved in training, is that it's probably not a good idea to fight for cultural competence. It's
Hmm.
much better to focus on cultural humility, right?
Hmm.
So, because anybody can be humble. Anybody can say, well, what I did when I went to West Africa for the first time is I didn't pretend I didn't know anything about Ebola. That's not true. I didn't pretend that I wasn't an infectious disease expert or someone who lived on the continent for 10 years.
Hmm.
What I did was to say, there's going to be so much I don't know. I don't
Hmm.
speak the local languages. Uh, and so I should just go into everything, assuming that I don't know. And then I'll take notes on things that startle me and surprise me. And that's what I did, and, I would encourage all of you to think about this notion of cultural competence more critically, and focus on cultural humility. And,
Hmm.
my impression of the folks, your age, and I teach a lot, is that actually there is quite a bit of cultural humility these days. So I'm even heartened there.
Hmm. It's good to hear. Well, Dr. Paul Farmer, thank you again so much for your time. This has been an enlightening conversation, at least, and we here at the Naval Academy wish you continued success in your quest to heal the world.
Thank you, Mason. I really appreciate it. And you got to tell Dr. Fauci he could be the Secretary of Defense, but I'm still a
You're still the
Navy.
Navy SEAL. Well, thank you so much,
Thank
Dr.
you
Farmer, for
all.
your
My
time.
regards to the other midshipmen and to the faculty and staff. And thank you for having me, Mason.
Have a great day.
Thank you.
Dr. Paul Farmer's appearance at this conference was made possible through the generosity of Bob and Marnie McKinney and the McKinney Family Foundation. Bob has been a friend of this conference for many years, sponsoring the annual McKinney Address and being a friend to the Naval Academy and the conference in many other ways. A native of Indianapolis, Mr. McKinney attended the Naval Academy, then served in World War II for 3 years in the Pacific Theater, including time on the staff of General Douglas MacArthur. After the war, he returned to Indianapolis, where he attended law school, then was called back up to serve in the Korean War. After the Korean War, he pursued a career in finance and in law, founding a bank and a law firm, as well as other corporations. His commitment to community-based banking led to his becoming the chair of the Federal Home Loan Bank Board, the Federal Savings and Loan Insurance Corporation, and the Federal Home Loan Mortgage Corporation. The law school he attended in Indianapolis is now named the Robert H. McKinney Law School. He served on the board of the Carter Center, the Sierra Club, and the Naval Academy Foundation, and was the chair of the Sierra Club board. Mr. McKinney shared a long marriage with his late wife, Arlene, and is now married to Shelley Barr McKinney. He and his 5 children actively manage the McKinney Family Foundation, with its emphasis on solving Indiana's environmental issues and its longstanding and deeply appreciated commitment to supporting this conference. Thank you.